Hi, good evening, everyone. So, welcome you all to Unacademy. Yeah, hello, hello, uh, hello, Shirvil Tyagi. Okay, so those who are joining the Unacademy for the first time, those who are taking the class for the first time, let me tell you about the iconic subscription where you get Unacademy and Prep Ladder both at a very competitive price. And we have question bank and lot more for you. So please join Unacademy and take maximum advantage of it. So let us quickly start with the flashcard based revision session. Okay. So. Okay, tell me. All except are false for this lesion. All except are false for this lesion. What can you see in the image, students? What can you see in the image? It's a very straightforward question. You can see a typical PUD orange. Yeah. So you can see a typical PUD orange appearance. And when we talk about PUD orange, what is the concept of PUD orange? The concept of PUD orange is nothing but, so since this is the dermis, there is infiltration of the dermal lymphatics. So there are a lot of dermal lymphatics in this. So the infiltration of dermal lymphatics by the tumor cells. And when there is infiltration of the dermal lymphatics by the tumor cells, there will be edema in this part, yeah, because the lymphatics are blocked, the fluid will not be able to escape out, and that is why you have the typical swollen orange peel like appearance or PUD orange appearance. Yeah, so this is all except are false. We want the true one. Yeah, it is due to infiltration of Cooper's ligament, students. This is absolutely false. Why? Because it is not the Santosh. Are you getting the answer? Arihan, you have also answered the same thing. D. Bachi, it is due to invasion of dermal lymphatics. So invasion of dermal lymphatics. So it is not infiltration of the Cooper's ligament. It is due to infiltration of the dermal lymphatics. What will happen if the Cooper's ligaments are infiltrated? What will happen, students, if the Cooper's ligaments are infiltrated? Infiltration of the Cooper's ligament will lead to teeth ring. So it will lead to teeth ring. So teeth ring, or you can say dimpling. This is due to the Cooper's ligament invasion. Are you getting this? Yes, according to AJCC, this is T4B. This is absolutely right, and this is due to invasion of dermal lymphatics. So option A is wrong. Let us quickly discuss, since we are talking about T4B, let us quickly discuss the staging. Let us quickly discuss the staging of this. Okay, let us discuss this. When we talk about the TNM, yeah, when we talk about the TNM of CA breast, what is T1? Oh, hi. How are you? Shubham Sharma. Okay, you were there. You used to attend the class, and then you just vanished. Huh? You forgot Dada. Okay, God bless you. I remember you. So TNM, when you talk about, let us talk about AJCC 8th version. Yeah. So when you talk about AJCC 8th, T1, let us quickly, within 1 minute, we'll revise this. Less than equal to 2 centimeter. Yeah. T2, more than 2 up to 5 centimeter. T3, more than what? 5 centimeter. What is T4, students? This is any size with what is T4A? Into chest wall. Remember, when we talk about the chest wall, invasion into the pectoralis major is not included here. Then what is T4B? That is into skin. When we talk about invasion into the skin, what are the specific points? It includes only 3 things. What are they? It includes PUD orange. So PUD orange. What else it includes? It includes, if the word PUD orange is not given, the word edema must be given. It includes the satellite nodule. Yeah. So satellite nodule, satellite nodule. What else? What else? It includes the word ulcer. The word ulcer. What is T4B? T4C now. T4C now. Yeah. When you talk about T4C, this is skin plus chest wall. Skin plus chest wall. And what is T4D, students? This is inflammatory cancer. This is inflammatory cancer. So yes, if it is said in the question, if you see the question, it is according to HSAC, it is T4B, absolutely right. So this is what is a typical PUD orange. PUD orange. Let us quickly see. What about the N? So when you are revising the TNM, let us revise it completely. N1 is mobile level 1, level 2 axillary lymph nodes. When you talk about N2, what is N2, students? N2A. The mobile lymph nodes now become what? Fixed. So fixed level 1, level 2 axillary lymph node. What is N2B then? It is ipsilateral. It is ipsilateral internal memory lymph nodes. Internal memory lymph nodes. Then what is N3, students? N3A. Ipsilateral infraclavicular lymph nodes. When you talk about infraclavicular lymph nodes, that is level 3. N3B, both. It is internal memory, and along with that, yes, the axillary lymph nodes. And what is N3C? It is ipsilateral supraclavicular lymph nodes. Supraclavicular lymph nodes. Let us go to the next question. Quickly, let us go to the next question. Okay. Come on, let us discuss this question. Comment on the incisions. Comment on the incisions. Yeah, just whatever you know, you can just type it. So this is this. Comment on the incision. Come on, students. It's a very easy thing. Whatever you write the number and tell me what it is. Now, let us see. Incision number 1. What is incision number 1? It is midline vertical. It's a midline vertical incision. Midline vertical. Where do we use this incision? This is used for laparotomy. Laparotomy. Incision number 2. We have a Cocker's incision. We have a Cocker's incision. We make Cocker's incision in the neck also. Here also we make Cocker's. So there are 2 Cocker's. One is for thyroid surgery and one Cocker's is for gallbladder and CVD surgeries. The third incision that you have is thoracoabdominal. Thoracoabdominal. When you talk about thoracoabdominal incision, students, this is for what? This is for diaphragm surgery, renal surgeries, aortic surgeries, pulmonary surgeries. Yeah. Then what is fifth? Bachche, fifth and sixth, fourth and fifth. Let us talk about fourth and fifth now. Fourth. If you talk about fourth is a rectus splitting incision. Oh, there's some problem. Okay. Fourth is a rectus splitting incision. Bachche, rectus splitting. And fifth is, what is fifth incision? This is paramedian. Paramedian. Bachche, today both these incisions are obsolete. We are not using these incisions. But classically this was used for gallbladder and CVD, and paramedian was used for exploratory laparotomy. Exploratory laparotomy. Yeah. Then sixth, we have a vertical. Sixth, we have a transverse. Now I am going to make one more incision here. But just see this, right subcostal, left subcostal, and let me label it 6A. What is this 6A? This is what is known as a chevron. Chevron is equal to rooftop. But both these incisions, they are for pancreas. So for pancreas or pancreatic surgery, we make them. But incision number 7, incision number 8, they are both made for appendix. Yeah. Let us see these incisions. Can you tell me what is 7? Incision number 7. This is the McBurney's. McBurney's. Or you can say gridiron. So McBurney's or gridiron. And then 8th is Lanz. But the difference between McBurney's and Lanz is also known as a bikini crease incision because it is low lying, hidden under the crease. So it's the Lanz. And both of these incisions are made for appendicectomy. Appendicectomy. If you talk about the 9, what is 9? Phenensteel. Phenensteel. What is this phenensteel incision for? Come on, students. What is this phenensteel incision for? Answer is for genitourinary tract surgeries, GUT surgeries, or LSCS. Yeah, LSCS. Then what is 10? What is 10? That is McEvady's. This is McEvady's incision. And this is for femoral hernia. This is for femoral hernia. What is this 11? Rutherford Morrison. Rutherford Morrison. Now what is so important about this Rutherford Morrison? Yeah. So let me in a nutshell discuss the incisions that we make for appendicectomy. So today, very often, very rare, in very small centers only we are doing open appendicectomy. Otherwise, open appendicectomy is not done. Try to understand the incisions that we make for open appendicectomy. This is umbilicus, this is ASIS, and this line is known as your spino-umbilical line. This is a spino-umbilical line. So lateral 1/3 and medial 2/3. We have a point which is known as McBurney's point. This point is known as McBurney's point. So this incision, this is known as, suppose, 1. Then we have an incision which is a bit low lying. This is 2. Then we have incision which is which is transverse like this, 3. But 1 is your McBurney's, 2 is your Lanz, and 3 is your Rocky Davis. 3rd is your Rocky Davis. But they are the 3 classical muscle splitting incisions. The question was this year in INI-CT, what are the muscles we split? External, internal, transverses. Yeah, we do split them. So external oblique, internal oblique, transversus abdominis, and then we go down. So muscle splitting incision. Muscle splitting incision. Are you getting this? But just sometimes there is a lack of space, and then in order to create some extra space, what we do, we go for medial extensions or maybe the lateral extensions. But now very rare people are doing these things. We go for a laparoscopic. We go for laparoscopic appendicectomy. Why laparoscopic appendicectomy has become a gold standard? Because we don't have any problem of space. Why to work with a compromised space? But there are people who are going. So you can go for a lateral extension. But if there is a lateral extension of any incision towards the flank, this is what is known as Rutherford Morrison. So we have Rutherford Morrison. And here, but if you go for medial extension, so medial extension, This is known as a Fowler-Weir incision. A Fowler-Weir incision. So these are important points. Yeah, this is what is Fowler-Weir incision. So बच्चे, medial extension important is Rutherford-Morrison and Fowler-Weir. They're all muscle cutting incisions. So they're muscle cutting incisions. Are you getting this or no? This is simple, very simple. Let us discuss one more important easy questions. Let us discuss about the surgical blades. Good evening, happy shappy. Yeah. Give my salam to everyone there. Okay. So let us talk about the surgical blades. Let us talk about the surgical blades. So these surgical blades are very important. We get question on the shape, we get question on the number, everything. Yeah. So let us see. Blade number 10. What is the use of this blade number 10? We go for minor surgery. Blade number 15. Again, bache, this is used for minor surgery. Blade number 22 and 23. They are taken for major surgery. Yeah. Now, what about this? What is this blade known as? This is known as a stab. This is known as a stab. When we talk about the stab, what are the uses of stab? Let us see. What are the uses of stab? When we talk about the uses of stab, they are very simple. Incision and drainage, point number 1. So incision and drainage is one thing. The next very important thing is you can use it for venotomy. So vein puncture, venotomy or arteriotomy. What else? Where else? If you have seen my videos on laparoscopic, if you see how I create a port, I use this blade number 11. So for port creation, if you have still not seen, you can go to my YouTube channel and you can see there. What else? Apart from this, perforator surgeries. For perforator surgeries, for drain fixation. So these are all the places where you actually use this blade number 11. So stab is a very important blade. This is a stab. This is stab. And these are all the uses of the stab. Let us move forward. Let us discuss one more MCQ for the day. Yeah. Let us talk about the zones of the burn. Zones of the burn. What is the classification that we are talking about? This is known as the classification of Jackson's zones. So Jackson's zones. Next is, so we have Jackson's zones. We have zone of coagulation, zone of stasis, and zone of hyperemia. Zone of coagulation, zone of stasis, and zone of hyperemia. Yeah. Perforator, bache, stab avulsion, perforator surgeries. That is what, beta. Jackson's zone of coagulation is 100% necrosed. So this is a zone which has undergone liquefactive necrosis. Zone of stasis is a zone where actually there is vasoconstriction. If you see, the zone of coagulation has already been destroyed, and this is the zone which is next to the zone of coagulation. Therefore, this is again very vulnerable. So the most vulnerable zone, answer is zone of stasis, because zone of coagulation has been already destroyed. Okay, what is zone of hyperemia, students? What is zone of hyperemia? This is the zone with vasodilatation. Remember, this is the zone which is farthest, and then you get the normal skin after that. So this is what is the concept of zone of coagulation, zone of stasis, zone of hyperemia. Is that clear or no? So zone with vasoconstriction, zone 2. Zone with vasodilatation, zone 3. Most vulnerable zone, zone 2. Zone with increase in thromboxane A2, Thromboxane A2, if you don't remember, still remember it like this. Is that clear to everyone or no? Yeah. Let us talk about one more easy question. Let us see. Okay. Okay. Identify this instrument. Identify this instrument. Come on. And identify its utility. What is this instrument? I'll zoom it again. This is a linear cutter stapler. Why do you see linear cutter stapler? Since the arrangement of the pins are straight. Can you see the pins are arranged like this? There are 4 rows of pins. Therefore, it is a linear stapler. Why do you say it's a cutter stapler? Can you see this sharp blade? Can you see the blade which is hidden? Is that clear? Can you see this blade here? This is the place where you have the blade. I think, no. It is because of the obvious resolution aspect. That is the reason. So, image requires, but we use it bariatric surgery, we use it for majority of the GI surgeries. Yeah. So, these are my own hands. This is my own stapler. Okay. So, bachcho, why it is known as a linear cutter? Because not only, suppose you fire a linear cutter, 2 rows of pin on each side will be fired, and then a blade will fire and divide it in between. So a blade will actually divide it in between. So not only does it cut, suppose not only does it cut, it will also what? Simultaneously seal also. That means it will seal with the staplers. So this is what is a linear cutter. What is this? This is a linear stapler. This is a linear stapler. Why it is a linear stapler? Because a straight cartridge will fit, which will be having a lot of pins. Yeah. Generally 3 rows. So this is a linear stapler. Why it is a linear stapler? Because of the straight arrangement of the pins. Why it is not a cutter? Why it is not a cutter? Because no blade is there. Are you getting? So this can seal but not divide. Are you getting this or no? This is T stapler. This T-shaped stapler is particularly used in colorectal surgeries. Sir, what stapler used for sleeve? Dekho, in sleeve, it depends upon the patient's choice and the surgeon's choice. When you are dividing the antrum, we use a green. So generally 2 loads of green is sufficient. Like I use this only. And when you go for the proximal part, then you switch to the blue. Yeah. So green and blue, this is what is a combination that we use. So green, because green is for thicker tissue. Blue, it's for a thinner tissue. Is that clear? I'll tell the color codes and I'll tell their color codes also. So let us try to understand. So stapler colors. Yeah. So stapler cartridge. Cartridge. If you see green is for thick tissues, therefore for stomach. Blue is for bowel. White is for pancreas. and also for vessel. Do you know now we even have got a bifurcation in this? For artery we have a different stapler. Yesterday only Johnson J&J people were sitting in my office. They were saying, sir, we have got a new stapler. Why don't you try it? We can demonstrate to the students at your training institute. So they have just come because I should allow the students to practice this in their training so that they can also use that. So nowadays even we have got an arterial white which is having some different, you can say, pin size in comparison to the venous white. Next is, so green, blue, white. What else? We also have a golden. We also have a black. But they are also for thick tissues. You can use it in bariatric. In bariatric surgery, generally over stomach, you can use a golden or a black also. Is that clear? So green, blue, white. Green, blue, white. This is what. So this is all for today. If you enjoyed the class, do join the Plus. Plus is actually having a lot of things for you in addition to the basic revision. And please use the code Dr. Dixit. Recommend the class, recommend Unacademy to your friends also. So till then, bye-bye. You can use the code Dr. Dixit to avail some discounts. So till then, bye-bye. I hope you enjoyed. Do give your feedbacks also for the class. Any problem in the part that we have already discussed today? Okay. I had sleeve 5 years ago and now I saw myself. Sir, I had sleeve 5 years ago and now I saw it in. Oh, great. Okay. No, you can also become a surgeon. You can also learn. That's easy. That's very easy. Sleeve gastrectomy is one of the most easiest surgery if you say. Till then, bye-bye. Hope you enjoy.